Is it really reflux?
Good morning, everyone. I'd like to thank Dr. Thompson and Dr. Franco for moderating this session, and thank you all for listening. Honoured to speak to you today. I'm a clinical research fellow with Dr. Michael Friedman in Chicago, and for this paper, the title of which differs slightly from the abstract you have in your book, the co-authors present today are Dr. Friedman himself and Dr. Christian Samuelson, so I'd like to acknowledge them as well. So the value of routine pH monitoring in the diagnosis and treatment of laryngopharyngeal reflux as it applies to the adult population. And obviously Mr. Eckhart, pictured there, has gone on to have a successful acting career. That's quite a good success story related to diagnosis and treatment.
So there are three main ways in the adult population that LPR is typically diagnosed. Either the symptomatic response to PPI treatment, and that symptomatic response is usually measured as improvements in the RSI, which has already been described by Dr. Markham. Thank you very much. The endoscopic findings, usually the RFS, also described to you earlier today, or ambulatory pH monitoring, which has long been considered the gold standard. There are a few issues regarding the diagnosis and treatment of LPR. The dual lumen pH probes that had typically been used have been shown to be not well tolerated by patients, and a previous study has shown that the RSI cutoff of 13 or greater has been correlated well with pH events at a threshold of 4, but in the same study not at a pH of 5. It's been shown that mucosal damage can occur at higher pH thresholds due to the prolonged activation of gastric pepsin, and I think Dr. Andrews referred to a level of 5.6 in his earlier talk. And there's been a hugely variable response to empiric PPI treatment in a number of studies. So using the ResTech probe, also the DX pH probe, also described by Dr. Andrews earlier this morning, in a previous study, we found that 80% of patients who were compliant with PPI treatment for 3 months, who had an RSI of greater than 13, had a significant improvement in their symptoms. However, in that same group of patients, the positive predictive value for LPR as diagnosed by a positive Ryan score using the DX pH probe was found to be only 56.6%. So an RSI of 13 or greater only had a 56.6% positive predictive value for a positive Ryan score. So in short, this was rather confusing, and we thought we ought to look into this a bit more. So the objective of this study was to define the real need for pH testing in the diagnosis of LPR by clarifying the relationship between the reflux symptom index and the pharyngeal pH environment. Our hypothesis was that we should be able to correlate the symptom severity measured with the RSI to pH abnormality. And in particular, we thought that because of the continued activation of gastric pepsin up to pH thresholds of 6.5, that total percentage time below pH thresholds of 6.5 and lower should correlate to symptom severity. So our methods: this was a retrospective review of a prospective database of patients, 163 patients who underwent pH monitoring with the DX pH probe, aged older than 18. And so the indications to offer pH monitoring to these patients were either an RSI of greater than or equal to 13 or any suspicious finding on the endoscopy. So any finding comprising those made up in the reflux finding score on endoscopy, the presence of one or more findings was enough to warrant, we found that to be enough to offer pH testing. So looking back on this data, after people had undergone 24-hour pH monitoring, they were separated into two groups based on either a positive or negative Ryan score. Now the Ryan score has not already been described this morning, so I'll go into that briefly. It was developed in 2009 by Dr. Ayazi and Demester and their colleagues. And it comprises three main components, which are measured in both the supine and upright positions. The percentage time below a given pH threshold, either upright or supine, the number of reflux events below that threshold, and the duration of the longest event.
and a composite score is made. So the patients in our study were compared at baseline for their characteristics, age, sex, BMI, and a history of smoking. Their mean pre-test RSIs were measured and compared. And also we looked at the proportion of each group, either Ryan positive or Ryan negative, based on their scores, who had an RSI of greater than or equal to 13. And so we looked at the percentage time below pH thresholds using this probe over a 24-hour period. Below pH thresholds 6.5, 6, 5.5, and 5, both upright and supine, and combined. So the results of the study. The only significant difference we found between these two groups was in their BMI, with the Ryan positive group BMI 30.47 plus or minus 8.22, and Ryan negative you can see just over 27. That was not surprising given that obesity is a recognized risk factor for both gastroesophageal reflux and laryngopharyngeal reflux. Surprisingly, there was no significant difference, statistically significant difference in the mean RSI between these two groups. And the sensitivity, specificity, positive predictive value, and negative predictive value of an RSI greater than or equal to 13 with respect to a positive Ryan score, I'll describe in the next few slides. So the sensitivity. So 55.7% of patients with Ryan score confirmed LPR would be correctly diagnosed in our patient sample by an RSI greater than or equal to 13. 47.3% of patients without Ryan score confirmed LPR would be correctly identified by an RSI less than 13. The positive predictive value, 44.3% of the patients with an RSI greater than or equal to 13 would be found to be positive on probe testing. And possibly the most important of all of these findings is the negative predictive value, in that 58.7% of patients with an RSI of less than 13 will not have Ryan score confirmed LPR, which means that over 40% of those with an RSI of less than 13, which has been the traditional symptomatic cutoff, will have the disease if you test them with the probe, if you consider a positive Ryan score to be positive for LPR. So we then plotted linear regression analysis of RSI in all patients versus their percentage time spent below, total percentage time spent below a given pH threshold. And you can see that there's quite a disbursement of the data points there. We did the same at pH threshold 6, 5.5, and 5. And again, there's not as much of a correlation as we would have expected. So the discussion. Our findings were not at all what we expected. We felt that we should be able to correlate symptom severity as measured by the RSI to percentage time spent below given pH thresholds, and we included those thresholds right up to 6.5 given the activation of gastric pepsin. However, we found that there was a very poor correlation. Over 55% of the patients with an RSI greater than or equal to 13 would have tested negative. And we decided to look at what could be affecting this. We found a history of smoking to be statistically independent from an RSI greater than or equal to 13 in this group. Previous study by Dr. Oyer and colleagues looked at over-reporting of the RSI as a result of anxiety and depression. Now, this was not something we controlled for in this study. However, looking at the results of their study, when looking at a group of patients without any history of anxiety and depression, the RSI was seen to correlate reasonably well to pH findings on the DX pH probe. When combining those figures with the RSI scores and pH scores for patients with a history of anxiety and depression, the positive predictive value in that group fell significantly more than the negative predictive value. In other words, over-reporting of LPR symptoms as a result of depression is more likely to artificially deflate the positive predictive value of the diagnostic utility, but the negative predictive value should only be minimally affected. So applying this to our own study, we can say that our positive predictive value of 44% may be artificially lowered by the fact that we haven't controlled for anxiety and depression. However, our negative predictive value
of only just over 58% should be only minimally affected. So over 40% of patients in our population with an RSI of less than 13 would be found to test positive on pH testing. Questions raised by this is, would this be an indication? Is this an indication that these less symptomatic or asymptomatic patients in some instances should receive treatment? And are these relatively asymptomatic patients at similar long-term risk as their more symptomatic counterparts as a result of their reflux? Okay, sure. Using a similar diagnostic, adjusting the RSI cutoff to 17 based on the 95% confidence interval of patients in our study, we found that the diagnostic utility was not improved. So in our patient population, we were unable to reliably diagnose LPR on the basis of symptoms alone. And whatever the method of choice, we felt that some form of confirmatory testing should be considered before commencing treatment in patients with LPR. Thank you very much.